Good evening, everyone. Thank you very much for logging in this evening. My name is Marco Raftopoulos. I'm a paediatric and adult ENT surgeon. Our rooms are in Edgecliff in Sydney. And I'm doing some common conditions within ENT for pediatrics. I'm ambitiously taken on quite a few topics, so we'll try and get through as many as we can. Really what the goal here is to try and delineate between ongoing close observation and specialist referral for common pediatric conditions. So I think, practically speaking, when we can observe further in the GP setting or when we need to think about referral onwards. So I'm going to touch on ears, noses, and throats. And specifically, we're going to look at obstructive sleep apnea and the recurrent sore throat, middle ear conditions such as glue ear and recurrent acute otitis media, and if we can get to it, allergic rhinitis and epistaxis as well. So jumping right into it, I thought I would just start with a general case, something which I would assume is commonly seen within the GP setting. So in front of you is a 4-year-old boy, and the comment is that he snores like his father. He occasionally has had sore throat, and there's been 5 courses of antibiotics required in the last 12 months. He's needed hospitalization on 2 occasions, and it's resulted in prolonged periods off preschool. He had an uncomplicated early childhood and is developing normally. Parent states that he's not a great eater, and on his centiles, he's probably on the smaller side. They've mentioned in daycare that he can be a bit of a handful, and he's often in bed by 8 o'clock. He needs a night nappy on occasion, and most mornings he comes across as quite grumpy. So I'm sure this is, fairly representative of many cases that have sat in front of you. So with that in mind, you look in his mouth, and sorry, excuse the graininess of the tissue, but you can see a child clearly got tonsillar hypertrophy. So in this instance, there's a couple of things going on that we need to dissect. So in this section, we're going to look, as I mentioned before, obstructive sleep apnea and the recurrent sore throat, to which this child touches on both of these topics. So we'll start with obstructive sleep apnea. Sleep disordered breathing, or OSA, they kind of get grouped into this concept of obstructive sleep disordered breathing, and it's really characterized by recurrent or partial or complete upper airway obstruction during sleep. Really, this results in just poor quality sleep secondary to abnormal oxygenation and ventilations, and this interrupts sleep patterns for children. Diagnosis critically can be made on history and examination in the primary care setting. And then there are adjuncts such as audio and visual taping, and then extra things like sleep studies. So I think critically from a primary care point of view, history and physical examination are where we can make most of the gains in the initial diagnosis of obstructive sleep disordered breathing. What are our causes? Broadly speaking, there's going to be 3 main ones: far and away adenotonsillar hypertrophy. Specifically, it's going to be the combined volume which correlates the severity. So although a child clinically can have high-grade tonsils, if their adenoids aren't enormous, then their risk of obstructive sleep disordered breathing isn't necessarily as high, but they do tend to come hand in hand. Other conditions include hypotonia that we see in the muscular dystrophies, and intermittently craniofacial abnormalities that we tend to see in the tertiary setting. This picture is a child with Pierre-Robin sequence, and you can see that they've got severe mandibular hypoplasia and concurrently would have a palate abnormality as well. These children are at high risk of sleep disordered breathing, and so they obviously needed to be supported in a tertiary care setting as well. So what's the significance? Why do we worry about sleep disordered breathing? And really, it's the effects of poor sleep on a child. And, many of us have children. I certainly have 2 kids, and, when they've slept poorly, you see those manifestations. And what we worry about is when children have had poor sleep every single night for their entire lives. And what are the manifestations of that? Well, the obvious one is an increase in behavioral risks. And these can be categorized as externalizing or internalizing. These kind of children can be aggressive or hyperactive, or on the reverse, they can be depressed, or they can have low mood, or they can have inattention as well. And this can have flow-on effects to school performance. They have poorer memory and attention. And in the severe OSA group, there's quite a lot of evidence to suggest that actual IQ is lower in the severe OSA group than the non-OSA group. This correlates with poor quality of life. In addition to that, there are some physiological consequences. So they can have secondary enuresis, so bedwetting overnight, failure to thrive, their asthma can be exacerbated, and they can have a lot of teeth grinding as well. There's a link there that I've put up, which summarizes it nicely. The position paper by the American Academy also covers these topics as well. Essentially, there's a lot of pathophysiological consequences of poor quality sleep. And so that's why it's really important to intervene in some capacity with these children. So how do we focus the history? Well, I tend to group them into nighttime symptoms and daytime symptoms. So I really get a strong sleep history of these children. When do they go to sleep? When do they wake up? How many hours of sleep? And does that hours of sleep correlate to their level of daytime function? So can they have 10 hours or 12 hours of sleep and then still be really grumpy? That tells you something's not going right overnight. Do they snore? How often? How loud? Can you hear them outside their bedrooms? Are there periods where the child stops breathing? For how long do they stop breathing overnight? Kids generally should be sleeping through the night as they get, from 18 months onwards, but are they continuing to wake up over their night? And then how do they look when they sleep? Do they extend their neck? Are they mouth breathing? Are they bedwetting at night? And can they have night terrors? In terms of the day, to what extent do they wake up energized? Are there behavioral concerns throughout the course of the day? Do they still require daytime naps even when they're getting older? And then other things as well, such as poor appetite, poor weight gain. And do they just not able to breathe and eat at the same time? That often tells you that their oral cavity is really crowded. So moving on to the examination, general inspection. So these kids, when they walk into my room, they essentially tear the room apart. They do not sit still. They go and they look at everything. They look at the otoscopes. They play with the microscopes. They're all over the room. And the poor parent is often frantically just trying to keep them in the one place. And, that's a really very quick indication that this child, there's something going on here. Their size, height, and weight. Is it representative of their age? Are there any obvious craniofacial issues that haven't yet been determined? And just as you can see in the picture there, does this child have an open mouth and a flattening of the malar eminence, typical of adenoid facies? Look in their mouth, get a tonsil grade, because as we mentioned, it's the combination of the tonsil and adenoid volume that's going to contribute to the OSA. And do they have any adjuncts such as audiovisual? So for me, that's really priceless. So I think the role of the GP in this instance is to obtain, and that's where most of the gains are made, to be honest, through the history and the examination, a sufficient diagnosis of obstructive sleep disorder breathing. In terms of further investigations, we don't necessarily need them immediately. I really don't think there's much of a role for a lateral X-ray, for instance, to look at adenoid hypertrophy. You can get a lot of that from the initial clinical examination, and we can do a nasendoscopy if required in our rooms. Sleep studies I certainly wouldn't be organising off the bat. They can be hard to access and expensive and probably unnecessary. So referring on for further evaluation. So what do we do? So again, we revisit the history and examination. I often ask parents, have you got any adjuncts? Have you got the sound of the child snoring? Have you got videos of them snoring? Because that is absolutely priceless information. We can do a nasendoscopy to assess the level of terminal hypertrophy and more specifically the adenoid hypertrophy. To what extent is the postnasal space filled with adenoid tissue contributing to this? Further investigations, I order them when the history and the examination don't match. When it doesn't make sense what's sitting in front of me. Is a child having terrible quality sleep but absolutely no tonsillar hypertrophy? That's when I start thinking about sleep studies. Are there any other factors? Are there BIS, neuromuscular, are there craniofacial abnormalities? And then ultimately, we have a discussion with the parents. Is there a role for further observation, or do we need to consider removal of do we need to consider an adenotonsillectomy? You know, there is not one solution for all. It has to be an individualized decision, and that is going to be based on the pathophysiology of the child that's sitting in front of you, the concerns of the parents, the clinical indication. And really, it's got to be a balance between the risks of surgery and untreated obstructive sleep disordered breathing. And in the severe instance, untreated sleep disorder breathing really does have some consequences. So, you know, a considered decision is vital in these instances. So moving on, the next thing to discuss is recurrent sore throats. So obviously, as primary care physicians, this is something that this group would be incredibly comfortable with dealing with. I'll just jump straight to how we consider, especially the role of tonsillectomy in the recurrent sore throat patient. So we use the Paradise criteria, as I'm sure you're all aware. And just to summarize it quickly, essentially, we're looking for documented evidence of a sore throat, and by which we mean a patient with high temperatures or cervical lymphadenopathy or an exudate, and that would be 7 or more episodes in a single year, 5 episodes in concurrent years, or up to 3 in multiple years in a row. So these are fairly strict criteria, and so we do have some modifiable elements to it, and these are our factors. So there are recognized exemptions, so effects of illness on the child and the family. If the child is sick all the time and it is and it's not quite 7 a year, but maybe it's 5 or 6, and this child is requiring time away from school, that's pulling a parent out of their work, that, you know, there's something to be considered in discussing the role of tonsillectomy in this instance. Are there known allergies to antimicrobials, making the antibiotic stewardship difficult? And are there other illness-related absences that are resulting in poor school performance? Is this kid, you know, missed out on half a term because they've been sick all term? We have some known specific clinical conditions. Periodic fever, aphthous stomatitis, pharyngitis, adenitis. Has the child had a peritonsil absence? Although rare in the young age group, it's possible. We generally see it from about 8 to 12 onwards. And do they have a very rare syndrome, which is PANDAS, which is an autoimmune neuropsychiatric condition? And then other things to think about is, are there febrile seizures, muffled speech? Do they have terrible breath? So these are other secondary reasons, in addition to the recurrent tonsillitis, that we would then have a discussion about the role of a tonsillectomy. So just touching on adenotonsillectomy in itself, it's the most common surgical procedure in children worldwide. It's increasing in Australia, and that's because we are becoming more thorough in our assessment and our understanding of the consequences of obstructive sleep disordered breathing. Just as a statement here, in the pediatric age group, far and away, it's going to be obstructive sleep disordered breathing. That's the primary indicator. As children get older into adolescence and teens and 20s, then it kind of drifts more towards recurrent tonsillitis. It costs the government about $2,500 to do this operation. We have multiple techniques, all of which have got their pros and cons, but ultimately, from a risk point of view, they all share very similar risk profile, and they tend to be an overnight stay, although in the right patient, it can be a day stay. Often a question about immunity. There's certainly absolutely no clinical impact of tonsillectomy on the immune system. Multiple studies support this. So that's a common question that I receive. So something to just comment on as well, because as primary care physicians, there's going to be the complications of adenotonsillectomy. So far and away, the most important one that we comment to children, to parents of children who are having this operation, is the bleed risk. And it's approximately about 5%, and it's regardless of technique. There's no real instigator in an otherwise normal child. We just know that that is our bleed rate. And they often have a very well pre-planned pathway if they do have a bleed. More in terms of where they would present to a GP would be in the context of other things such as pain and fever and infection. So pain, this is, especially in the adolescent and older age group, a terribly painful operation, but in children also very uncomfortable, but they tend to do better than the older group. The pain is really severe, and it can be, and peaks during days 5 through to 10. They often have ear pain. The main thing is that they get dehydrated, which exacerbates the pain. They used to use a codeine medication for children, but that's since now changed completely. And we tend to generally treat these patients with regular ibuprofen paracetamol with supplemental oxycodone. Fever is common in the first 5 days, but if it tends to go past fever in the second week of recovery, then it's unlikely going to be an infection. Rather, it's going to be a concurrent upper respiratory tract infection. Infections are rare. There's no role for antibiotics in our perioperative management of tonsil patients. And so I just thought I'd show you these pictures, and because this is a normal postoperative appearance for the tonsil. Essentially, there's a sloughy exudate secondary to fibrin deposition in the throat. And what that does is it gives this awful appearance of an infection, where in fact they don't actually have one. It's just part of the recovery process. So I recognize that, you know, a child sitting in your practice with a throat like this, you know, it would make sense to think about antibiotics, but it generally doesn't represent any type of infection, just the secondary healing that's occurring in that region. Their breath smells terrible, and parents will tell you that always, but all of these stuff, it tends to be resolved within the first 2 weeks. So just kind of to retouch on that topic again. So this child is snoring. They shouldn't snore. Although he has had 5 courses of antibiotics or multiple episodes, he's got a couple of modifying factors. He's needed hospitalization. He's had time off school. He's not eating well, and he's having some daytime behavior. So, you know, there's ample evidence here to have a serious discussion in and around the role of adenotonsillectomy for this specific child. Moving on, we're going to touch on a couple of the ear conditions. So second case study, sitting in front of you is a 22-month-old girl. She's had recurrent middle ear infection, so 3 so far this year. Mum's worried, and she's not sure whether the child is just kind of ignoring her or can't hear, which, if you know, anyone who's got a 22-month-old knows that can be a hard one to delineate. Her word count's not great. She's at 5 individual words. No concerns in the antenatal, perinatal period, passed a newborn screening test, developing normal but tends to fall around, a bit clumsy, and is currently in daycare. All right, so you look at their ear, and on the left-hand side, I beg your pardon, on the left-hand side, you can see a eardrum that looks like this. This is a normal eardrum, so this child clearly has a middle ear effusion. It's got a straw-colored appearance rather than white appearance, so it's not an active acute otitis media. Rather, there's simply a thick glue ear that's present in this child. So I just want to touch on some of the nomenclature because it can be a little bit confusing. We use a couple of different terms interchangeably. When we say middle ear effusion, we're essentially talking about any fluid that's present in the middle ear. And that can be like a thick exudate of glue, it can be pus, it can be blood. So middle ear effusion is a broad term. And that occurs when there's an acute otitis media or when acute otitis media evolves into a lingering effusion. Acute otitis media, as this group would be very aware of, is where there's rapid onset of signs and symptoms of inflammation of the middle ear. Otitis media with effusion, it's the natural sequelae of acute otitis media, and it's essentially the exudate that gets left behind when the infection clears, and it becomes a chronic condition when it lasts for more than 3 months. So touching on recurrent AOM, this group, like with the recurrent tonsillitis, would be incredibly experienced in managing acute otitis media. The pathways are well established. I just wanted to touch on a few comments here. There's obviously host-related factors and environmental factors. This gives a bit of evidence to support the main things in each of these. So level A evidence for the younger group, so 6 to 11 months tends to when it occurs. The children are of Indigenous background tend to be of higher risk and they have more severe disease. The immunosuppressed and those with the genetic predisposition also have a higher risk of acute otitis media as a host-related factor. From an environmental point of view, there's no grade A evidence with the NIH MRC, but there are some level B evidence. So daycare, having a sibling, having upper respiratory tract infections, exposure to smoke, and using a dummy as well increases the risk. So, so in particular, from an ENT point of view, it's when the acute otitis media becomes recurrent acute otitis media. And the general classification is if a child is having more than 3 episodes of acute otitis media in a 6-month block, or whether there's 4+ in about a 12-month block. In addition to all the previous risk factors, and it was touched upon there, prematurity and low birth weight puts kids at risk of this, early onset acute otitis media, and other factors such as daycare and smoking. So we can see here a bulging white drum, typical of an acute otitis media episode. Briefly on the pathophysiology that drives this, essentially we have vertical contamination from the nasopharynx. We have pathogens that sit there, influenza and pneumonia, it's pneumonia as well. And when the eustachian tube fails, so that's either refluxing of the eustachian tube up into the middle ear, or conversely, poor clearance of middle ear disease out of the eustachian tube, you tend to have a accumulation of infection in the middle ear. Once the middle ear is colonized, biofilm can enter into that space, and that's always very difficult to move. A network of microbes which set up a structural network that induce recurrent infection. Often, if it's not an acute infection, there's a lot of exudative accumulation, which because of the failed eustachian tube fails to drain. And so what you end up getting is this cycle of a semi-sterile effusion and ongoing infection exposure. And that's what sets up our recurrent infection. Why is it a problem? Well, recurrent acute otitis media can lead to adhesive middle ear changes. You can get necrosis of the ossicular chain, resulting in hearing loss. You can have retraction pockets, leading to chronic suppurative otitis media, the end result of which can be cholesteatoma. And you can also have local suppurative complications, mastoiditis, abscesses, etc. As I'm sure you're all aware, we have a couple of red flags. We want to see these patients earlier, the particularly young, the immunocompromised, the indigenous population, 1 hearing ear cochlear implant patients, and those who have had suppurative complications before. So what are our options? Our options are essentially 2 things. We can either give these children prolonged antibiotics, so 3-month prophylactic antibiotics, and they're fairly effective in reducing the number of episodes, or we can consider a grommet or tympanostomy tube insertion. Pros and cons of each of these. The advantage of having a tympanostomy tube is you essentially can evacuate the middle ear effusion that's present in the middle ear that's driving this infection, and facilitate, instead of recurrent oral antibiotics, instead these patients can use ototopicals. So the burden of antibiotic exposure in terms of oral medication goes down. When a patient has a infection, you'll notice that the patients with tympanostomy tubes won't have high fevers, they won't have as much severe pain because it all drains out, whereas in the non-intervention group, they will continue to have their normal AOM signs and symptoms. Of course, a tympanostomy tube involves a general anesthetic, and with it carries perioperative risks, albeit very small, but nevertheless present, and antibiotics you don't. Next slide is essentially a reiteration of the same thing, but I really wanted to kind of touch on that these groups, more than anything else that I say to parents with this group, is that, you know, yes, we're going to reduce the number of infections, but it's the same as antibiotics. Ultimately, what we're doing is we're taking the antibiotic burden away from this child, and we're allowing ototopicals, which are essentially 100 times more efficacious than oral antibiotics in the treatment of these bugs, as well as relieving some of the symptoms associated with it. So middle ear effusion with OME, or the glue ear patient, which is what we kind of saw at the top of this case. We consider it an occupational hazard of early childhood. It's part and parcel of the growing space within the nasopharynx, and the ear itself. Glue ear is fluid in the middle ear without acute infection. And broadly speaking, patients who've had recurrent otitis, who've had failed eustachian tube dysfunction, or are recovering from an acute otitis media episode can develop a glue ear. Now, for 25% of patients, this will persist for more than 3 months. And why that's important is because it can have clinical implications, least of which are going to be a hearing loss in a child, balance problems, poor school performance, and ongoing other concerns, so behavioral concerns, ongoing ear pain, recurrent acute otitis media, and for the child themselves, poorer quality of life. So we think about developmental difficulties as part of the, as additional risk factors for this group. So any child who's got these extra things, we really need to act early to try and treat them. So we want to take a focus history, a perinatal history, developmental history. We want to ask about hearing loss, and we want to ask about how frequently they're having their infections. We have here a couple of questions you can ask a parent. How would you describe your child's hearing? Have they misheard words from you? And are they having difficulty in a group of people? These are really excellent screening tests, because if they fail 2 or more, it gives you a really strong indication that this child's likely to have some loss. Here are the communication milestones that we see with groups of kids. This is through speechpathologyaustralia.org. And they look at the expectations of what kids should be doing at most ages. And if we think about our 22-month-old, they should be approaching 50 words, and they're not in this instance. So examination with a otoscopy, we want to look at the ear like we did at the top. If you can do it in the right age child, we can think about a Weber's. And then in addition to that, audiometry. And I cannot stress enough how important this test is. So what you're seeing there is a VROA, which is a visually reinforced orientated audiometry. It's a puppet test. You'll see a small little puppet here in the corner. What happens is a child is in a booth, a loud sound comes on, a big flash, big puppet, they turn their head. So you prime the child, and you do it at different decibels to try and induce a response. And you see how quiet you can go before the child stops turning their head. You'll get a audiogram that looks like this. And in this child, this is a patient I've had recently, they've got a 40 dB loss. And because you can't pick the ear, so it's going to be their global hearing. So at best, this child in their better hearing ear has got 40 dB. And critically, their timps are flat on both sides. So this child has got evidence of a middle ear effusion. I think if you're going to take away one slide from this whole presentation, I think this is probably the best one to take. With a child, when they've got a middle ear effusion like this, they can have up to 50 decibels or 40 to 50 decibels of hearing loss. So that means they are missing out on normal speech, which means the consultation in which they are attending, they probably can't hear it properly, or it sounds like they're underwater. So that gives you an indication when you see a child with a middle ear effusion, they probably can't hear you properly. And that helps your frame of reference in terms of, how important it is to act on this child, and how long are we prepared to leave a child in this position before we want to act on it. So as I mentioned, documented signs and symptoms of ear disease, evidence of delay, is there recurrent acute otitis media, is there speech and language concerns? We have an indication for grommets when we think there's chronic effusion with loss or recurrent acute otitis media, but they're not without their complications. They can fall out early, they can get blocked, they can get infected themselves. General water exposure rules. Evidence suggests that there's no problem with water exposure as long as they're not dropping their head below 1 meter. My general rule of thumb is I say, don't worry about the bath, but if you're going to put a child in the pool, they should have some kind of ear protection. So revisiting the study again, this is our little one. She's got recurrent middle ear infections, 3 so far this year. So within a 6-month block, that's an indication. Poor word count, but mum is worried. So that is a strong indicator, because if mum is worried, that tends to be a good indication that something's not right. And being a little bit clumsy is evidence of vestibulopathy, which could suggest, could be secondary, from the middle ear effusion itself. So I'll just ask Lydia, do you want me to keep going? The last few slides will take a few moments, but if you want me to stop, I can stop.
We might just go for another 1 minute. And we'll
okay, sure.
Thank you.
Okay, no problem. So 2 last things just to talk about: allergic rhinitis and the runny nose. Allergic rhinitis, IgE mediated type high sensitivity. Important thing to know is there's a priming and a late response. The primary response is what's going to induce the itchiness and sneeze, and that's your mast cell degranulation. And the late response is the eosinophilia, which results in tissue remodeling in your nasal obstruction. In Sydney in particular, grass pollens and house dust mites are our primary culprits. These kids tend to have watery rhinorrhea, they have nasal obstruction, sneezing and itch, but they look like this child over here. They've got these dark patches under their eyes, the Denny Morgan lines. They have this allergic salute, which is this little line over their bridge of their nose. And the inside of their nose likes this hypertrophied, wet, boggy tissues with these spindles that look like very classic of allergic rhinitis. Our approach is a ladder. Firstly, we need to work out what's their allergen, and that helps us modify the environment if it's possible. Our medical treatment is going to involve symptom control, which is antihistamines and intranasal corticosteroids, plus consideration of immunotherapy. Surgery has a role to relieve the blocked nose, and it helps deliver sprays for better control. Last slide, history of epistaxis. We see this all the time. I want to know, how long has it been there for? How frequent? Is the child got any underlying coagulopathies? What treatments have been used? My red flags, if it's a male and it's unilateral, because there's a risk of a JNA, which is what this big vascular lesion in the back of the nose looks like. First aid treatment with good nasal pressure, consideration of nasal cream, and then refer to us if there's any ongoing bleeding. So I think there were a few questions if we have some time. Our team is in East Sydney and we service the full range of ENT, so happy to help at any point.
Thank you, Marcos. That was an excellent topic. So I've got a few questions. So somehow I think it has been answered by your presentation anyway.
Okay.
Studies.
Yeah.
So I think the first one will be, what is the preferred dose for prophylactic antibiotics for recurrent otitis media?
Yeah. So it's a 6 to 12 week dose of amoxicillin, and it's going to be the milligram per kilogram dosage escapes me just at the moment, but it's at the lowest possible dosage, but for a 6 to 12 week period.
It's okay. The next question, what is the risk of recurrence of acute otitis media after tympanostomy?
The risk of recurrence after tympanostomy?
Tympanostomy. Yeah,
so the tympanostomy tube will reduce the number of episodes from about 3 to 1.5 per year, which is similar to prophylactic antibiotics. So the goal here is to try and obviously reduce the number, but also reduce the symptoms that are associated with the acute otitis media itself.
So I was asked to speak today on pediatric general surgery. Although I treat adult and pediatric cancer patients as a subspecialty area, this talk is going to be on pediatric general surgery exclusively, as is relevant to general practice. The talk is entitled Top to Toe and In Between, and so we'll be covering head and neck, abdomen, and inguinoscrotal, and even something on the feet in half an hour. So we're going to move quite quickly through the slides, and I'll be happy to take questions in the same way if you just type them on the question and answer forum, and then we can answer them either at the end or I'll type back to you. So what the most common tumor of childhood, and happens to be a very common presentation in general practice, is this lesion here. This is a 4-month-old girl who presented with a what is colloquially known as a strawberry nevus on her forehead. It's actually a hemangioma. It started off as a little red dot on her forehead at birth and then grew quite quickly in the first couple of months of life. The natural history of these lesions is that they'll continue to grow until 7 or 8 months of life, even to 10 months of life, and then they'll start to regress, and they'll regress over a number of years. And they usually leave a little fibrofatty area. There's no indication for operative intervention in these unless they're in functionally significant areas like the nose, the nostril and the nose, the oral cavity, or on the eyelid, obstructing vision. And even then, we usually treat them with a beta blocker, and surgery is not usually required. So this is a hemangioma. Hemangiomas don't always present so obviously, and this little guy had a hemangioma in the submandibular area, which was thought to be a submandibular tumor, but on ultrasound it had the typical features of hemangioma, and as the child grew, the lesion regressed on its own and no operative intervention was required. Still in the head and neck, the two patients here are of different ages. One is a year and a half old child, and the other is a 12-year-old girl. Both have got external angular dermoids, which is a congenital anomaly caused by infolding of skin during the formation of the face in utero. An external angular dermoid, as you can see on the left of screen, can be quite small, but they do tend to grow over time. They can cause scalloping of the calvarium, and they're fairly straightforward to remove. They should be referred for removal because if they aren't removed, they can grow and get infected, as you can see in the girl on the right-hand side of screen, and then they have to be incised and drained and then removed at a secondary procedure. So that's an external angular dermoid. This midline lesion, many of you will be familiar with, is a thyroglossal duct cyst. It's a cyst that forms along the thyroglossal duct tract. The thyroid starts its life in the base of the tongue in utero and then descends along the thyroglossal duct tract through the neck, through the hyoid bone, and then comes to its position in the base of the neck where it is located in most people. It can leave nests of cells along the way, and sometimes these develop into cysts. A thyroglossal duct cyst usually presents in early childhood, but can present all the way into a patient's 20s. They're reasonably straightforward to remove, provided they've never become infected or ruptured, and they're usually removed with the middle portion of the hyoid bone. And if they're done in that way, there's a low level of recurrence. And so that's a thyroglossal duct cyst. The pathognomonic sign of a thyroglossal duct cyst is if you grab a hold of the cyst and get the patient to open their mouth and stick their tongue out, the cyst will move up because it's connected to the hyoid bone. This is another relatively common presentation in the head and neck. It's a branchial cleft cyst, a second branchial cleft cyst. They usually present in the retromandibular area, anterior to the anterior border of the sternocleidomastoid in children and young adults. They can be mistaken for cystic lymph nodes, and often they're even biopsied. And sometimes we can't tell that they're not lymph nodes until we've removed them and looked at the histopathology. They're relatively straightforward to remove through a small incision in the neck. The imaging of choice is an ultrasound, but occasionally we get an MRI just to delineate the extent of the lesion. So that's a branchial cleft cyst. This is a branchial cleft sinus. So it's formed through the same embryological error as a branchial cleft cyst, only the sinus exits at the base of the neck. The full length of the sinus goes from the base of the neck to the tonsillar fossa, but they're never complete. So these sinuses are usually limited in their length, and they can be removed through a stepladder incision up the neck, and provided you go up to where they peter out, they usually don't recur. So that's a branchial cleft sinus. It's the same embryological origin as a branchial cleft cyst. Now, these preauricular lesions are also relatively common. The one on the left of screen is a preauricular tag. Preauricular skin tags usually have a cartilaginous core. They don't have to be removed if they don't bother the patient, but frequently kids get teased at school if they have these. And so they're relatively straightforward to remove. The cartilaginous core also needs to be removed. Otherwise, they'll end up with a little lump just in front of their ear, which can even appear like a recurrence. It isn't a recurrence. It's just they shouldn't be amputated. They should be removed with the cartilaginous core. On the right of screen is a preauricular sinus. These are usually unilateral, but can be bilateral. If they're bilateral, the patient should have an ultrasound of their kidneys to make sure there are no renal anomalies with which bilateral preauricular sinuses are associated. If the sinus has never been infected and doesn't irritate the patient, they can be left alone. If they've ever been infected before, or the patient doesn't like them from a cosmetic point of view, they're relatively straightforward to remove. This presentation is also relatively common, but not very well recognized. And it is of a child who has presented with usually a preauricular or a submandibular swelling, which has grown over a period of weeks. And then suddenly the skin over the top becomes violaceous and starts to break down. This is an atypical mycobacterial infection of a cervicofacial lymph node in a child. It's due to an atypical mycobacterium, which is ubiquitous, usually resident in the soil. It occurs because kids have a tendency to occasionally eat dirt. The bacterium traverses the tonsillar tissue and then lodges in one of the cervicofacial lymph nodes. The lymph node necroses and then points through the deep fascia, and a collection forms beneath the skin, at which point the skin turns purple. We usually treat these with incision, drainage, and curettage, being careful to curette out the lymph node itself, and then the wound heals over a couple of weeks. I usually send these patients as well to infectious diseases specialists to make sure that they don't require a few month course of antibiotics to sort out any other lymph nodes that might be hanging around. This little guy has something that everyone will recognize as a tongue tie. He can't protrude his tongue past his teeth. There's a lot of literature regarding tongue tie. The tongue tie should be divided in a neonate if it's causing painful breastfeeding or difficulty latching. That's probably the only hard indication for a tongue tie release. But I'd released this kid's tongue tie because he couldn't protrude his tongue past his lower incisors, which means he couldn't clean them with his tongue, which would almost certainly affect his dental health, and he may, as a result, get dental caries. And also, there was the problem that he was getting teased at school about it as well. And so, once I divided it, he was a lot happier. There's a lot of literature which discourages dividing tongue ties, but I think we can be quite discerning in our indication. And if the indication is there, a division is a relatively straightforward thing to do under a quick general anesthetic. It's a day procedure. So moving out of the head and neck now, further down into the abdomen. This is the most common presentation in pediatric surgery, the humble umbilical hernia, which can be quite large and very worrisome to parents. But even when they're this size, they almost always resolve on their own. One just needs to be patient. I've only ever seen one of these incarcerate in my career. Incarceration is incredibly rare. You don't need to do anything particularly to it. They sometimes go blue if there's a little bit of bowel in there. But as long as it's an umbilical hernia and not a para-umbilical or supra-umbilical hernia, 95% of them will get better by the time the child is 4 years old. And the only time we fix them is before the kid goes to school. This is an umbilical granuloma, which is epithelialized. They present often as moist intra-umbilical lesions, which can soil the clothing. They should be looked at carefully to ensure that they're not patent vitellointestinal ducts, which can communicate with a Meckel's, or what you would probably know as a Meckel's diverticulum, or a patent urachus, which would connect with the bladder. If you see bowel content coming out of these, or urine, then it's one of the other two things, and they should be referred for investigation and excision. But this simple umbilical granuloma, which is epithelialized, can just be removed as a day procedure. Now, the next photo I'm going to show you is of a fairly unwell child. So if that is going to worry you, it's best now to look away. The picture on the left is taken 100 years ago and is a picture of a child who has hypertrophic pyloric stenosis. You can see on the right-hand side of the child's abdomen, there's a mass. That mass is the hypertrophied pylorus at the exit of the child's stomach. On the right-hand side is an ultrasound done significantly sooner than 100 years ago, which shows a pylorus which is thickened here, sitting next to the stomach here. This is the liver here. That pylorus is too thick for food to go through. The way that these children present is with projectile vomiting. From the age of 3 weeks to 3 months is the usual age bracket, but they can present earlier than 3 weeks. So they have projectile vomiting, and then after that vomiting, they're very hungry because everything that they eat, they end up vomiting. And so they end up ravenously hungry and very miserable. The child on the left didn't benefit from surgery, but when Professor Ramstead started operating on these children, he tried to do a stricturoplasty, but the muscle was so thick he couldn't actually do it. So he just left it with a longitudinal incision in it, and then the children just spontaneously got better. So he found out that this operation by complete accident. But as a consequence, these children present to hospital. We rehydrate them over a period of 12 to 72 hours, depending on how dehydrated they are. And then once their electrolytes have been corrected, we operate on them laparoscopically through 3 millimeter incisions, and we divide the pylorus. We do a pyloroplasty laparoscopically, and then they usually go home the day after or within 2 days, and once they're feeding. Interestingly, if you go back into their abdomen 6 months later for any reason, you can't see any evidence that a pyloroplasty has been performed. The lesion on the right-hand side of the screen is what an intussusception looks like. If a child presents with intermittent abdominal pain, they're pulling their legs up and they're either obstructed or they're passing red current stools with abdominal distension. Between the ages of 3 months and 3 years, one should suspect an ileocolic intussusception. On the right-hand side, on the left-hand side of the screen is an ultrasound showing a target lesion, which is a pathognomonic of an intussusception. We usually manage these with air enemas. So you put a tube up into the patient's anus and then blow air into the colon at about 80 millimeters of mercury, and it usually concertinas the bowel out like one of those long balloons. Occasionally that's not effective and we have to operate, and then usually we can squeeze the bowel out and resolve the intussusception. Very occasionally you get necrotic bowel and have to do a bowel resection. I've only had to do that a couple of times in my career. So abdominal pain with intermittent abdominal pain between the ages of 3 months and 3 years with leg drawing and red current jelly stools, think intussusception. This is a much more common presentation. This is appendicitis. You can see at the bottom of the screen here, this is the cecum and this is the inflamed appendix. This is an open appendicectomy. We hardly ever do these anymore. We usually remove the appendix laparoscopically. So if a patient presents with periumbilical shifting to right lower quadrant pain, nausea and vomiting, a low-grade temperature, and then tenderness in the right lower quadrant, they may have appendicitis. Interestingly, these days, we are treating more and more kids with appendicitis with non-operative management. There is definitely a cohort of patients that are safe to treat with oral antibiotics, particularly those without a fecalith in the ostium of the appendix. And certainly in the European setting, patients are being treated like that, and about 75% of them will never recur. The appendix is the repository of the gut flora. We now know that it has a function, and so that if we can preserve it, it may be that it's best preserved. In Australia, appendicectomy remains the gold standard. We're not yet at the point where we're treating these non-operatively as a matter of course. Differential diagnosis for appendicitis is Meckel's diverticulitis. So here you see a Meckel's diverticulum. They occur about 60 centimeters from the ileocecal valve. They're usually antimesenteric, and they present for a variety of reasons. The most common is painless bleeding in a child under the age of 2, but they can present with inflammation if their ostium becomes obstructed and they become inflamed. This is the diverticulum, which, if it connects with the umbilicus, will form a small bowel fistula with the umbilicus, the so-called patent vitellointestinal duct. A Meckel's diverticulum is usually treated with a small bowel resection because they contain heterotopic mucosa, often gastric mucosa, which can cause ulceration and is responsible for the bleeding in children under 2. Moving down further, the body, this on the left-hand side of the screen is a neonate with a left inguinal hernia, and the right-hand side of the screen is a 5-year-old with a left inguinal hernia. The difference between the two is that the 5-year-old can wait for their operation a few months with very little chance that they're going to incarcerate. The neonate cannot. If a neonate is diagnosed with a left inguinal hernia, they need to come to surgery on the next available operating list. If you were to call me to say to me, you have a neonate with an inguinal hernia and show and you were concerned about that and send a picture through, I wouldn't even consult with the patient. I'd just book them for surgery on the next list and get them into hospital before it incarcerated. This is different from this inguinal hernia as such, this used to be called a fluid hernia, but is in actual fact a communicating hydrocele, also caused by a patent processus vaginalis, but the patent processus vaginalis in this case isn't big enough to allow bowel or fat through. It's only big enough to allow fluid through, and so fluid collects during the day while the patient's wandering around, and then usually at night when they're recumbent, the fluid drains away. But they'll come to you complaining of a large testicle or a large hemiscrotum, and you may feel a fluctuant mass there. If you then put a torch against it and it transilluminates brightly, you're dealing with a communicating hydrocele. The operation to fix this is exactly the same as the operation to fix an inguinal hernia. And this can be, there's no urgency to fix this. It can be done within a few months. It's only inconvenient and it tends to get a bit larger and bother the patient, and occasionally can give them a dragging sensation, but they're not dangerous at all. This little guy has an undescended right testis. It's difficult to get a photograph of this because they're not usually obvious, but this one certainly was. You can see that the right testis is missing completely. His testis was in his inguinal canal. The ideal time to bring those testicles down is somewhere between the ages of 9 and 12 months of age. Occasionally you can't find them in the inguinal canal and they're in the abdomen, in which case we bring them down in a two-stage laparoscopic procedure. Often these testes don't function very well as an organ of reproduction, but they certainly do contribute to the patient's puberty. And it is really important to have both testes in the scrotum if possible in order for the patient to be able to self-examine when they get older, because of the increased risk of testicular malignancy in children with undescended testes. This boy on the right-hand side, you can see the testis is lying horizontally. Horizontally lying testis is a sign of a bell clapper deformity where the tunica vaginalis is investing too high on the spermatic cord. The problem with that is that it predisposes them to testicular torsion. If a boy presents with testicular pain, they need to go straight to the emergency department at a children's hospital for evaluation. You don't need to get an ultrasound. You don't even have to ask that many questions. Just send them in for evaluation. What you want to try and avoid is this. This is a 15-year-old boy who had testicular pain. He ignored it and didn't tell his parents, and he ended up with an infarcted testis. We used to see, if we saw these, we used to remove them. Nowadays, we just stick them back in the scrotum and they usually atrophy. And if any gonadal tissue survives, it may contribute to their fertility. But there used to be a concern about anti-sperm antibodies. They don't exist, and so you don't need to worry about them. But this is something that you definitely want to avoid. This is a torted hydatidal morgagni, or a torted testicular appendage. It's the main differential diagnosis for a torted testis and is far, far more common than a torted testis. A patient will present with often days of scrotal pain. When you examine the scrotum, you may see a little blue dot on the top of their testis. That's pathognomonic for a torted hydatid of morgagni. We often operate on these just to relieve the patient's pain, but if they don't have that much pain, they're often sent home, and within 5 to 7 days, the pain will resolve once the hydatid has necrosed. This last slide is moving away from the scrotum down to the toes, which is another common pediatric surgical problem. On the left of the screen, you can see a low-grade ingrown toenail. If you look at how this child's cut his toenails, you can see that he's cut the corners out into the paronychial fold. That is not a great way to cut your toenails. It's setting you up for a ingrown toenail. It's much better to let those corners grow out and to cut the nail flat. This can usually be treated with massage and salt baths. What you want to avoid is what's on the right-hand side of the screen, where there's lots of granulation tissue and chronic infection with bacteria and fungus. This will unfortunately only get better with a wedge resection at surgery. That is usually done under either a quick general anesthetic or local anesthetic and sedation, depending on the maturity of the child. So I've covered a lot of topics. I've got 1 minute to go, it looks like. We've covered everything from the head down to the toe, as was the purview of the talk. So now I'd encourage you to ask any questions that you may have, and I'll try my best to answer them.
Thank you, Gideon. Our first question here, would you preemptively surgically fix a bell clapper deformity to avoid future torsion?
Yes. So if you can identify bell clapper deformity and horizontal lie, then yes, I would definitely consider preemptively fixing those. A scrotal orchidopexy is a very straightforward procedure. We make a midline scrotal raphe incision. We deliver the testis from the tunica vaginalis. We make a window in the tunica vaginalis, and we simply suture the tunica auberginea of the testis to the tunica vaginalis to prevent it from torting, and then the testes are safe.
Thank you. So the next one is, at what age should we refer a patient with undescended testes?
If the testis has not descended by 3 months of age, it will not descend. And the ideal time to operate on them is between 6 and 9 months. So the earlier you refer, after 3 months of age, the better.
Okay, so next one is on the umbilical granuloma. So do we always have to remove it, or we can leave it alone? And do we use silver nitrate even in a sort of fairly young baby, like a newborn?
If you have an umbilical granuloma which is small and you use silver nitrate, that may be all that's required to treat it. But if the granuloma epithelializes like that one did, that won't respond to silver nitrate and needs to be removed surgically.
Okay, good, thank you. I think that's all we have. Thank you very much, Dr. Gideon Sandler.
Well, thanks very much for inviting me. My contact details are on.
Okay. Yes, as mentioned, a little bit of an Olympic flavour, sort of following on from the Olympics. There were certainly some interesting sort of moments in the Olympics. There's some great sort of moments from an Australian perspective, of moments of great mateship. There was moments of friendship and sportsmanship. And the other thing that, of course, always interests me is the age of the athletes that are present at the Olympics. So not necessarily a new phenomenon. Sort of in the lower half of the screen, we've got a 12-year-old Japanese skateboarder and a 12-year-old Syrian tennis player. But of course, we can see some young Olympic athletes from previous years, Nadia Comaneci. Interestingly, this is Tom Daley, who won a gold medal about 14 years on from this image. In many ways, I look at the Olympic motto of Citius, Altius, Fortius, higher, faster, stronger, and think about its relevance in terms of paediatric sports medicine. And the reason for that really is the changes that we see sort of during puberty. And so I was going to spend about the first 5 to 10 minutes of the talk just talking about some of the changes that we see in association with puberty, and then the importance of that in terms of the patterns of injuries that we see, and then highlight a few sort of common injuries and how to manage those. So puberty, of course, is the defining event of adolescence, and the timing and tempo of puberty differs between girls and boys and between individuals. And typically, sort of with girls, we see sort of an onset of puberty anywhere between 9 and 14 years of age, usually sort of beginning by the age of 10, and then sort of boys usually offset by about 2 years. This next graph is a graph that sort of demonstrates height velocity and quite relevant in the context of paediatric sports medicine. And the reason for that is the changes that we see in the skeleton, which I'll highlight sort of in a little while, in the skeleton and the musculoskeletal system. So again, we see that sort of that offset where sort of in girls we see a peak growth period at about 12 years of age, and in boys offset by a couple of years, 14 years of age. And of course, there's maturational variation depending on the timing of onset of puberty. So what happens as kids develop from a sports perspective? Well, they get increases in aerobic capacity. So they get increases in anaerobic power. So that's more your sprinting capacity. And we see increases in strength. We see improvements in motor skills. And we also see increases in cognitive development, which obviously have an impact on sport from a sort of a skill perspective and a planning perspective. This is a nice table that's sort of derived from youth athlete development models that sort of are often used in sort of academies, football academies, etc., sort of overseas. And I think from a medical perspective, it sort of shows some nice highlights in terms of what I'm talking about. So we see development of fundamental motor skills being sort of really sort of core in early childhood, but still continuing on sort of throughout adolescence. We see an increase in very specific motor skills sort of through adolescence. We see increases in agility, speed, power, strength, etc. The next slide is essentially the same slide, but it's just offset 2 years, and because of that sort of offset in the timing of puberty. I won't focus on each of the individual things in terms of, aerobic capacity, anaerobic power and strength, but I just wanted to highlight aerobic capacity just to provide an example. This graph demonstrates peak VO2, which is the maximal oxygen uptake that we see. Kids, interestingly, are slightly different. They don't have a maximal VO2. They peak out rather than plateauing. Hence the difference in terminology. What we see in this graph here is that we see increases in peak VO2 that are timed around the time of the peak height velocity. So really, it's just mirroring those graphs that we saw sort of previously, and again, sort of boys being sort of offset slightly. This graph just highlights the changes on the basis of whether kids are early maturers, average maturers, or late maturers. So if they are early maturers, they tend to have higher peak oxygen uptake than those who are late maturers. And so really, as with most things during adolescence, we should really be making a consideration of what is the impact of maturation, where is the child from the point of view of their the tempo and timing of maturation, because that influences so much of what we see in terms of sports medicine. We see a similar pattern in girls, not quite as pronounced, and mainly because of the differences in muscle mass. Despite all these increases in strength, increases in power, increases in skill, we also see a very particular issue where children are essentially more fragile. And that fragility is due to specific changes that happen in the musculoskeletal system, and indeed various other areas of the body. So if we look at the risks of being a young athlete, there's an increased risk of musculoskeletal injury. There's an increased risk of concussion, an increased risk of prolonged symptoms following concussion. There's an increased risk of heat-related illness due to the way in which adolescent bodies cool themselves. Increased risk of collapse and syncope and cardiac death in young athletes, an increased risk of overtraining when we compare to their adult athlete peers. There's also some general risk of being young, and these are not specifically sports related, but they're certainly important in the context of managing children who play sport. They have prolonged responses to viral illness. They have increased incidence of orthostatic intolerance, increased risk of mental health disorders, and increased risk-taking behaviours. And so that certainly influences managing their return to sport. So I'm going to focus now predominantly on musculoskeletal issues. Obviously, an important issue in general practice. This is a paper that I did with some colleagues, just looking at the rate of presentations to general practice for musculoskeletal conditions, and we can see it really sort of peaks sort of around sort of adolescence. Interestingly, it drops off in girls, which has probably predominantly got to do with participation rates, but it's certainly one of the more common sort of presentations to general practice, and I think representing about 30% of presentations. If we look at injury epidemiology across different sports, the key feature here is that there are certain sports that have a much higher risk of certain contact injuries, and that would include concussion, and that's things like rugby union, rugby league, AFL, and extreme sports such as skateboarding. Most of those issues don't happen in junior sport. So with modified rules, we actually see very low injury incidence in junior sport, but certainly as soon as kids hit adolescence, then we start to see quite a marked increase in injury incidence. And the majority of that injury is musculoskeletal in nature. And really the key concept that I wanted to share with you this evening is that adolescents have both an increased risk of injury, but also a very unique pattern of injury compared to other athletes. When I say other athletes, adult athletes. And why is this? Essentially, one of the first reasons is just the fact that of the presence of growth plates, which is one of the most common areas of injury. If we look at this diagram here, we have the physis, which is responsible for longitudinal growth, but often forgotten is the apophysis. And so this is the tibial tubercle apophysis, the site at which Osgood Schlatters is common. But essentially, children have an apophysis anywhere where a tendon inserts onto bone. And so anywhere in the body that they use repetitively, then you can see a similar clinical scenario to what we see in Osgood Schlatters disease. So I'm sure many of you are familiar with other eponymous versions of traction apophysitis, such as Sever's disease, but there's numerous others, some of them named and some of them not. But important considerations, important to have an understanding of anatomy to make a diagnosis. The other reason that we see significant changes is increase in pubertal hormones, and they have a significant sort of influence on the growth plate and bone mineralization in particular, things that I wanted to focus on here. And really what I'm looking at is what's happening with tissues, those skeletal and muscular tissues during maturation. We know that articular cartilage is weaker, certainly from animal studies, and the collagen matrix increases about 100-fold as children mature. We know that the growth plate is thicker and therefore it's more fragile, and that's true of both the epiphysis and the apophysis. We know that bone mineral density actually decreases during that peak growth period, that peak growth spurt. So you get a relative drop in bone mineral density. And that explains why we see that period of peak pubertal growth as the period for peak fracture rates in terms of long bone fractures. But it's also a period that we see other injuries, which initially are thought to be less common in kids, but are actually relatively common. So stress fractures are actually quite common in sort of children, in particular with repetitive sport. And then, unfortunately, we see an increase in muscle mass, but that increase in muscle mass precedes the changes in bone strength indices. And so you've essentially got stronger muscles, but weaker bones and weaker growth plates. And you can see why we get the pattern of injuries that we do. So how does that apply then in a clinical setting? And what are some of the injury patterns that we see? I just wanted to focus on a few specific injuries and talk about them. There's obviously quite a range of injuries to go through in a brief period of time, so I've chosen a select few. The first one is a 13-year-old child who presents with a clicking knee. That was their sort of presentation. They said, my knee clicks. But in fact, they'd had bilateral knee pain for some time, at least about 3 months. It was bilateral, but worse on one side. The key feature of the pain was it was quite vague. If you asked the child to sort of say, oh, where is it? They could never quite describe to their parents where it was. It was never particularly sort of tender, sort of when their parents were poking and prodding around. The pain was generally worse with activity and corresponded to an increase in training. The child had been selected into a representative level of soccer and then had sort of doubled their training essentially. There was a little bit of clicking and grinding sort of more recently, which was the reason for presentation, but no swelling, locking or catching. On examination, the child had normal gait, but had a limp when they were running, had full range of motion of the knee without the presence of an effusion, but had tenderness over the medial femoral condyle. There's a specific test that was positive called Wilson's test. It's a test that looks for the presence of an osteochondral lesion in the medial femoral condyle. The test is performed by having the patient sit on the bed, internally rotating their foot, and then extending the knee from 90 degrees out into full extension. And they usually get some discomfort at about 70 degrees. On the basis of that presentation, an X-ray was done. This is a plain AP film, and you can see in this particular child, there's abnormal areas bilaterally in the medial femoral condyle that represent an osteochondritis dissecans lesion. And that's present there probably because of the soft cartilage that we were talking about a little bit earlier in terms of child with maturation. X-ray is certainly an excellent initial screening tool, but it can sometimes miss the lesion. So with a high clinical suspicion, it's not unreasonable to perform an MRI or certainly refer. This is the MRI of the same patient. What we can see sort of here is a small area of bone with a lower level of signal, but cartilage intact. So essentially at this stage, you've got osteitis, but without a chondral lesion. So this is a low-grade sort of lesion. I've put in these images. This is a different patient, but I wanted to sort of focus on sort of from an imaging perspective. When we send a patient for an X-ray, we will typically get an AP and a lateral X-ray. If you suspect an osteochondral lesion in the knee, then an important view to ask for is what's called a tunnel view. So essentially the knee is flexed, and then you can pick up that lesion in the medial femoral condyle. So this image is the same patient, but you can quite clearly see with a tunnel view that abnormality in the medial femoral condyle. Interestingly, sort of despite the normal AP, this one was quite a bit more significant lesion. I'll just show you here in this view here. This was the initial view, so quite an extensive lesion. The chondral surface is still intact, but we've got cysts here, and we're starting to develop a fluid cleft. And when you see that, the concern is that this is going to progress to a lesion that becomes unstable. And so it's important to try and pick them up before that. So essentially the treatment for these patients is rest, and that's never easy in junior athletes. This particular girl was fantastic in her capacity to rest and follow instructions. So I just wanted to show you the progression of imaging. So this is her MRI at about 3 months post, and so we see resolution of the cysts, but you can certainly still see some bone edema. It's looking stable in that there's no flattening of the cartilage surface here. And then this is today's, or I reviewed her today, sort of last week's image, and so you can see further resolution of that bone edema there, and again sort of quite stable cartilage. So so she was very pleased when I told her that she was going to be able to sort of increase her physical activity levels. We grade osteochondral lesions or osteochondritis dissecans in 4 grades. Grade 1 just being sort of osteitis of the bone. Grade 2 is where we start to develop a fluid cleft, but we still have intact cartilage. Grade 3 is essentially a lesion where we have breakthrough on both sides of the cartilage and fluid cleft visible on the MRI. And then grade 4 is an unstable lesion where it's dropped out and become a loose body. So from a management perspective, grade 1 and 2, we're looking at rest for 3 to 6 months, and clearly that's not easy in an adolescent. Modified activity certainly to help soften the blow. So if we can get them to cross-train by swimming, by cycling, as long as it's not heavy load of cycling or uphill cycling, but certainly I allow my patients to cycle with their friends a little bit. And this is particularly sort of useful. So this is a medial unloading brace. And so you can see this sort of strut sort of here on the medial aspect of the knee, just helps to unload the medial femoral condyle. The goal really of treatment of grade 1 and 2 is to prevent progression to grade 3 and grade 4. Poor prognostic factors for progression would obviously be starting with a higher grade bone edema with a fluid cleft, with progression of the lesion despite a restriction in activity. One of the main things that makes a difference is the pubertal status of the child. So children who are pre-pubertal generally tend to do very well and tend not to progress to grade 3 and grade 4. And that's probably because of their remodeling capacity, in the same way that their long bone fractures can remodel very nicely. These lesions tend to remodel very well. Those that progress need referral to an orthopedic surgeon for consideration of arthroscopic micro drilling or smart nailing, which is very clever little nails, as the name suggests, which basically pin the piece in place and prevent it from becoming unstable and a loose body. So this is my patient today, who kindly showed her very well worn brace for 6 months, but she was very excited that she was able to take that off with those images looking so much better. This is a table that I think is worth sort of just paying a little bit of attention to. The osteochondritis dissecans is one of the osteochondroses. The osteochondroses are growth-related musculoskeletal conditions in children. I like to divide them between extra-articular osteochondroses, intra-articular osteochondroses, and physeal. The extra-articular osteochondroses are the ones we mentioned briefly before, and I'm sure you're quite familiar with Sever's disease, Osgood-Schlatters disease. The reason I think it's useful to conceptualize them in this way is that it allows us to speak to parents and say, look, you know, your child with Sever's disease, its involvement of the heel, it's away from the ankle joint. There's no association with long-term damage to the ankle joint. There's no association with arthritis. There's no long-term complications. And so we can talk about modified activities, but also if the child does too much on any one sort of given day, it's not the end of the world. The worst thing sort of is that they're going to be a little bit more uncomfortable for a few days. Certainly gone are the days where we sort of recommend extended periods of rest for traction apophysitis due to the negative effects of rest in children. Intra-articular osteochondroses, on the other hand, we do need to recommend rest where appropriate, because really if we keep running around on our knee with an OCD lesion in the medial femoral condyle, then we're going to progress to a grade 4 lesion, and then this child will end up with osteoarthritis later in life. The physeal osteochondroses, just mentioning sort of briefly, a good example is the distal radial physeal injury in gymnasts. It's a very common one where they're sort of doing a lot of handstands, etc. You do have to be careful about resting them for until they settle, and that's just because you can sometimes get discordant sort of growth, and the slipped capital femoral epiphysis is a better known version of a physeal osteochondrosis. So moving on to another common injury, and we've been talking about the apophysis, and we're familiar with Osgood-Schlatters disease and Sever's disease as being conditions that can affect the apophysis, but the apophysis can be acutely injured. And so this is a 14-year-old boy who described his hip popping. He had an acute onset of left anterior hip pain. He felt a pop when kicking on goal. He was able to wait there, but unable to lift his leg, and he had swelling and bruising of the anterior aspect of his hip. On examination, he had difficulty walking, he had difficulty with hip flexion, his range was otherwise quite good, but he did not want a straight leg raise. He couldn't resist flexion in any way, and he was very tender on the anterior superior iliac spine. This is his initial X-ray, and what we can see here is a shadowing sort of here that's asymmetrical when compared to the other side, and that's a slightly displaced apophysis. It doesn't look particularly dramatic on the X-ray, but certainly when we look at the CT scan, this is an older patient, so this CT scan wouldn't be recommended today with the ability for us to get good access to MRI, but you can certainly sort of nicely visualize sort of the way in which the apophysis has been pulled off by the quadriceps muscle there. A very common injury sort of during that peak period of growth. It can happen in any of the muscles, more typically around the pelvis. It can also happen around the knee, but typically around the pelvis where we have these very strong muscles. So where the quadriceps inserts, where the adductors insert, where the hamstrings insert. So common examples. This is an example of a child who has had a hamstring apophyseal avulsion. And so we can just see a little, again, an asymmetry from one side compared to the other with that little line there representing an apophyseal injury. In terms of treatment, ice, as with any musculoskeletal injury, is critical. Crutches allow for protected weight bearing and essentially protect from pain, but also begin that process of physiotherapy. The imaging, certainly I wouldn't recommend CT, that was just for instructive purposes. An X-ray can certainly be useful, and in particular if access to MRI is not available. The X-ray, the main purpose is really to look for a significantly displaced fragment. If the X-ray is normal, you can still have a child who has an apophyseal avulsion injury. It just means that the apophyseal fragment hasn't displaced. So really the purpose for doing the X-ray is to look for a significantly displaced fragment that potentially needs referral for surgical fixation. Which ones do we surgically fix? It used to be any less than any that are displaced more than 2 centimeters, but in fact that seems to be sort of pushing out to 3 or 4 centimeters, and they actually heal relatively well. They need a good 6-week period of rest before they can return to play. Even the minor ones still need that period of time. I explained to the families that it's essentially like a fracture and should be treated as one. It's right on 8:30, but I've got one more case and I want to share this with you because I think this is really interesting and probably one of the more exciting changes from a management perspective in sports medicine, certainly in pediatric sports medicine. So this is a case of a child whose knee popped. He comes in saying that it happened when he was playing AFL. He was pushed off the ball as he was kicking, landed with his knee in slight valgus, felt a pop in his knee and had immediate pain and swelling. And that presence of immediate swelling is an important component of the history. It really implies that there's a significant internal derangement of the knee. So on examination, he had a large effusion. His range was quite restricted because of the pain and the effusion that he had. He had a little bit of tenderness of the medial collateral ligament, but no laxity. And certainly we see that the medial collateral ligament can be injured in association with the anterior cruciate ligament. But his clinical tests certainly indicated the presence of an anterior cruciate ligament tear with a positive anterior jaw and a positive Lachman's test. Initial management was ice, crutches to protect, and an immediate MRI to confirm the diagnosis. And getting an MRI is important to do in a short time frame, and I'll explain why in a moment. So this is a normal MRI, but it's just so we can orientate ourselves. This is the anterior cruciate ligament here. The best way of describing the anterior cruciate ligament, it's very nicely defined and sort of it sits up proudly as the integral ligament to the knee. And then this is our patient here. So what we can see is a different angle on that cruciate ligament. It's sitting down and sort of flopped down. We can see a change in the signal sort of here representative of a full thickness rupture of the anterior cruciate ligament through both bundles of the anterior cruciate ligament. This is the STIR images, the T2 weighted images, so we can see the effusion sort of here tracking up into the suprapatellar bursa. We can also see very high signal within the ligament itself. We can see a little fragment here which represents a small avulsion fragment, and certainly that's one thing to remember, is that children don't always have a mid-substance tear of their cruciate ligament. They can sometimes have an avulsion either of the tibial spine or up at the origin. And then we typically sort of see this bone bruising pattern, which is called a pivot shift bone bruising pattern. So the reason for the immediate MRI to confirm the diagnosis is the potential for a change in the way in which we manage these. And we can potentially brace patients within 10 days, if they're suitable patients, with the goal of healing. So it's previously thought that the ACL had limited capacity to heal, but in fact, it's now thought that it has a good capacity to heal. This is an example of one of a couple of my patients that has been managed with this new brace protocol. It's called the cross bracing protocol. It was developed by Merv Cross, who many of you will know is a very famous orthopedic surgeon in Sydney, and also his son Tom Cross, who's a colleague of mine at Stadium Clinic. And so Tom has really been instrumental, together with some academic physiotherapists in Melbourne, in moving this forward. The protocol itself involves fixing the knee at flexion at 90 degrees for 4 weeks, and then slowly bringing it out, and such by 12 weeks, bringing it out into full range. My very first patient, this is his MRI. So these are the images of the same patient that I showed you earlier. And what's fantastic to see is that we have healing of at least one of the bundles. So still not sort of full healing here. So obviously not quite ready to sort of get out and sort of play sport, but certainly a degree of healing. Why is this important in the context of pediatric sports medicine? Certainly in adults, and you can use this bracing protocol in adults for those who aren't interested in surgical reconstruction, or those who have had a previous ACL injury and therefore would not like to go through the same process again. But in children, we tend not to immediately go to surgery. The surgical procedure that we offer in adults basically drills through the physis. And you can get a growth arrest. And so you either wait for 4 or 5 years and sort of tell the child that they really can't play contact sports and football and change direction sports, or you can offer a modified procedure which spares the physis, but they still need a procedure at the end. Obviously, an important injury also just in women. This is one of our academy sort of girls. We've had 2 ACL injuries in the academy this year, and just to point out that the rates of ACL injury in females are 10 times higher than they are in males, for a variety of reasons. What I might do is flick past my last 3 slides, just given the time to summarize. So hopefully we've described sort of that adolescence is a period of increased risk of sport-related injury. but some of the patterns that we see are really quite unique and quite different to what we see in adults because of the presence of growth plates and because of that close link to adolescent growth and development. Thank you.
Thank you, Damien. Lydia, do we have time for questions, or we went over time already?
We're a couple of minutes over time, but I think we like to hear the questions and the answers, and we don't have too many.
Okay, good.
Thank you.
All right, so yeah, the first question, please, is do we need to worry about a rapid height growth?
You don't necessarily need to, I mean, I guess in a medical context, no. I think it's certainly a flag for an increased risk of injury. So the kids that we see who have a really rapid height growth are prone to a rapid change in their bone mineral density, and so in particular are at risk of stress fractures. The kids that really, I think, are at high risk with that very rapid sort of increase in growth are kids who are playing sports where back pain sort of is potentially a risk. So it's things like AFL, tennis, basketball. So with that rapid increase in growth, not only do you see a decrease in bone mineral density, but you see quite poor core stability. Just the capacity for the muscles to keep up with that sort of rate of growth is quite poor. And so it's really the peak time that we see injuries. So it's a flag for injury. It should also potentially be a flag for reducing load in kids as well. And so certainly some of the professional academies look at managing load sort of on the basis of anthropometric data.
Thank you. So the next question is about flat feet, and it says here, is there any exercise a child with flat feet can do, especially if they are very active?
Flat feet, definitely an area of contention. So, so I think it depends on what the goal is. If a child has painless flat feet, then and the parents are sort of coming sort of with either, you know, should I get orthotics? Should I wear footwear? Should I do exercises to improve the flat feet? No exercise, no orthotics, anything will change the mechanical alignment of the foot. But certainly if a child is getting pain in their feet, then exercises are quite beneficial. So strengthening tibialis anterior to lift that. We also sometimes look at flat feet in the context of injuries up the kinetic chain. So by that I mean if there's biomechanical abnormalities of the feet, that sometimes influences knee or hip or back pain. And again, it sort of depends. If somebody's sort of coming in and sort of saying, oh, my kid's got flat feet, you know, should I get orthotics because maybe they'll get injured? If they're not, you know, particularly active, then that's not necessary. If they're exercising sort of at high levels, then yes, it probably is necessary. The analogy I sort of always give is it's a bit like if your car's got tires that are slightly flat and, you know, the wheel alignment's slightly out, but you're just running up and down to the shops, and it really doesn't matter so much. But if you're driving to Perth or driving a Formula One car, then it's a significant issue.
Good, thank you. So the next question is about, I presume it's the last part of your talk. It's about the cross bracing. So it says here, what is the chance of healing with a cross bracing method? And also, if it's not working after 12 months, would you recommend a surgical repair?
So first question is a very good question. And the answer is we're currently sort of undertaking or beginning to undertake research studies. Certainly Tom Koss has larger data in adults. The data in kids, I think he's got about 10 kids, and certainly greater than 50% of those kids have healed. What seems to be important is sort of picking sort of those that are more likely to heal than sort of not. So there's certain prognostic factors, whether or not the bundle has flipped over or not. So there's some where it would seem it's not worthwhile. But certainly watch this space, because there will be some research, sort of, some robust research, as opposed to sort of case series that are looking at that. The advantage in children is it's not significantly different to how you would necessarily manage them. And certainly, for instance, for a child who had a concurrent medial collateral ligament injury, where you would need to brace them anyway at 30 degrees for 6 weeks. So this is bracing them for a slightly longer period of time at a different angle. And if they don't heal, then you would still progress into their sort of their rehabilitation, strengthening their quadriceps, etc. Would I recommend surgery? It depends on the age of the child, and it depends on their activity level. And when I say the age of the child, really their growth plates need to have closed to recommend the adult surgery that we recommend. And then again, sort of some of the evidence around sort of return to sport for the current gold standards of rehab aren't particularly sort of good. And so hence the reason for looking for either sort of surgical temporizing procedures or non-surgical interventions such as a bracing protocol.